Hey everyone, and welcome. If you're an MBBS student gearing up for exams, you are in exactly the right place. Today we're diving deep into two microscopic troublemakers that are pretty much guaranteed to pop up on your papers, Entamoeba Histolytica and Giardia Lamblia. Let's get you prepped to absolutely crush these topics. So let's start with the classic clinical question, right? A patient comes in with diarrhea. Is it that bloody, invasive dysentery caused by an amoeba? Or is it the fatty, foul-smelling kind you get from a flagellate? Being able to tell these two apart is absolutely critical. Not just for your future patients, but for acing those tricky exam questions. And trust me, by the end of this, you'll be spotting the difference in no time.
So here's our roadmap for today. We're going to kick things off by setting the stage. Then we'll do a deep dive into each parasite. First Entamoeba, our bloody invader, and then Giardia, the fatty adherer. After that, we'll cover the essentials for diagnosis and treatment, and we'll wrap it all up with some high-yield revision points to lock it all in. Sound good? Let's jump in. Okay, first things first, let's set the stage. We are dealing with two single-celled organisms, protozoan parasites, that cause totally different kinds of problems in the human gut. So let's meet our first contender. First up, we have Entamoeba histolytica. You know, the name itself gives you a huge clue. Histo meaning tissue, and lytica, which means to lyse or destroy. So right away, you know this is our tissue-destroying amoeba, the one that's infamous for causing true amoebic dysentery.
Now, Entamoeba exists in two main forms, and you've got to know both. On the left, you see the trophozoid. This is the active, moving, feeding stage. See those little vacuoles inside? The dead giveaway, the thing you have to look for, is ingested red blood cells. That's your proof that it's invasive. Then on the right, you have the cyst. It's smaller, tougher, perfectly round, and this is key, it has up to 4 nuclei. This is the infective stage that can survive outside the body.
The life cycle is a classic fecal-oral route story. It all starts when a person swallows the mature 4-nucleated cyst, usually from contaminated food or water. That tough little cyst makes it through the stomach acid no problem. Then in the small intestine, it undergoes excisation. It cracks open and releases trophozoites. These guys then travel down to the large intestine, which is their main playground, and that's where they can either hang out harmlessly or start to invade.
So how does this invasion actually happen? Well, once the trophozoites get to the large intestine, they use a special protein, a gal/galnac lectin, to grab onto the mucosal cells. Once they're latched on, they release these tissue-dissolving enzymes called cysteine proteases that just melt away the tissue. This allows them to burrow deep into the intestinal wall, and this creates the absolute classic pathology you see in textbooks, the flask-shaped ulcer, which is narrow at the top and wide at the base. Remember that term? It's a huge buzzword.
For your exams, you need a quick way to remember the clinical features. Just think of the patient being in amoebic pain. P is for pus and mucus in the stool. A is for abdominal cramps, that classic colicky pain. I is for invasive complications, and this is a big one, because this parasite can get into the bloodstream, travel to the liver, and cause a life-threatening abscess. And finally, N is for notable bloody stool, the absolute hallmark of dysentery.
Okay, listen up, because this table right here is pure exam gold. They love to ask you to differentiate amoebic dysentery from bacillary dysentery, like the one caused by Shigella. So let's break it down. Amoebic stool, it's copious, a lot of it dark red and smells really offensive with only a few pus cells. Bacillary is the total opposite. Small amounts, bright red blood, it's odorless, and it's absolutely packed with pus cells. You have to know this table. All right, let's switch gears. We're moving away from the bloody invader to our second parasite, Giardia Lamblia. This one, well, it plays a completely different game. It doesn't invade at all. It just adheres, and its calling card is causing a fatty, greasy, really foul-smelling diarrhea. Giardia's appearance is, well, it's unforgettable. The trophozoite on the left is pear-shaped. Some people say it looks like a tennis racket. It's got 2 nuclei that look like a pair of eyes, which gives it this weird face-like appearance. And see that big ventral sucking disc? That's what it uses to stick to your intestines. The cyst, on the right, is more oval-shaped, and it also has 4 nuclei. Just look at it. It looks nothing like an amoeba.
The life cycle here is also fecal-oral. Someone ingests the cyst, but, and here's the huge difference, everything happens way up in the small intestine, specifically the duodenum. The trophozoites come out, they multiply, and they use those sucking discs to attach firmly to the duodenal lining. I'm going to say this again because it's so important. There is no invasion into the tissue. They just form a carpet on the surface. So the whole problem here isn't tissue destruction, it's mechanical disruption. Think of it like this. By completely carpeting the surface of the duodenum, the trophozoites create a physical barrier. This flattens the villi, messes up the brush border, and leads to really bad malabsorption, especially of fats. And that fat malabsorption is exactly what causes the classic symptom of Giardiasis, steatorrhea, or fatty stools. No invasion means no blood. Simple as that.
So how do you remember the symptoms of Giardiasis? Easy. The name of the parasite tells you everything you need to know. Just remember Giardia. G for greasy, frothy stools. I for intestinal bloating and a lot of gas. A for abdominal pain. R for those really characteristic rotten egg burps. D for diarrhea, which is watery and non-bloody. And the last IA reminds you that it interferes with absorption.
Okay, so you've got the pathology down. You know the clinical features. Now let's get to the part that really matters. How do you prove it in the lab, and what are you going to do about it? These are the questions that will absolutely show up on your exam.
When you get that stool sample to the lab, the differences are just night and day. For Entamoeba, you're looking for a bloody mucoid stool. And under the microscope, what's the money shot? Trophozoites with ingested red blood cells. For Giardia, this stool is watery, fatty, and foul-smelling. And you'll see those unique pear-shaped trophozoids, often with a distinctive falling leaf motility. But you'll see absolutely no RBCs and no pus.
So yeah, stool microscopy is the classic gold standard, but you need a fresh sample and a really skilled technician. That's why in the real world, labs now often rely on stool antigen detection with tests like ELISA. They're super sensitive and specific. PCR is even better because it can actually tell the difference between the pathogenic E. histolytica and other non-harmful amoebas that look similar. And for Giardia, in tricky cases where stool samples are negative, you might see this thing called the entero test or string test used to get a sample right from the duodenum.
All right, treatment. This is super high yield. For Amoebiasis, the most important thing to remember is that you need a two-drug approach. You have to use a tissue agent, like metronidazole, to kill the invasive trophozoites in the gut wall and in the liver. But, and this is what people forget, you also need a luminal agent, like iodoquinol, to get rid of the cysts that are just hanging out in the gut. This prevents relapses and stops the patient from spreading it. For giardiasis, it's way easier. Usually, a single dose of tinidazole or a short course of metronidazole does the trick. Okay, we have covered a ton of information, so let's boil it all down to the absolute must-know facts for your final cram session. This is the slide you need to have seared into your brain on exam day.
Here we go. 4 points. Let's make it quick. 1. Pathology. Entamoeba invades the colon. Giardia adheres to the duodenum. 2. Stool. Entamoeba is bloody. Giardia is fatty. 3. Trophozoid. Entamoeba is an amoeba with ingested RBCs. Giardia is a pear-shaped flagellate. And 4. Complications. For Entamoeba, the big fear is a liver abscess. For Giardia, it's chronic malabsorption. Got it?
And there you have it, your complete exam guide to amoeba and Giardia. You are now totally equipped to tell them apart clinically, in the lab, everywhere. But to keep you on your toes, here's a final thought. What other parasites, maybe like the non-pathogenic Entamoeba coli, might you see on a stool report that could try to trick you? Keep thinking, keep studying, and you're going to do great. Thanks for joining me.